So I'll be talking today on approach to vasculitic diseases. Uh, Vasculitic diseases are some of the commonest uh, emergencies in rheumatology, uh, and they can come to any specialty, not only to rheumatologists. So every uh, physician, general practitioner, or specialist in any medical area can actually come across systemic vasculitic diseases, and there are a whole lot of them. So I'll be giving just a broad overview, which may be helpful for practitioners and the physicians. So vasculitis, as you know, the meaning is inflammation and necrosis of the blood vessels, resulting in impaired flow and function of the involved organs and systems in the body. So, in an overview of pathogenesis of vasculitis, I would like to just mention that vasculitis causes inflammation of the vessel wall. It can be neutrophilic, lymphocytic, or granulomatous. So normally, like we know from the pathology diagram of dolor, rubor, tumor, calor, and loss of function are the 5 pillars of inflammation, which is applicable to vasculitis also. So in this cartoon, I would like to explain that normally the white cells, the neutrophils, or the other white cells, they flow in the lumen very smoothly without getting stuck to the endothelial surface, and they do not come out of the vessel wall under normal circumstances, because the receptors for various pro-inflammatory cytokines like TNF and IL-1 and the ligands on the white cells, if they are not upregulated, they will not be causing an indirect interaction or stickiness, which is a requirement for inflammation. So under special circumstances, this situation may change. So whether it is autoimmunity, infection, or other causes, these pro-inflammatory cytokine and the receptors are upregulated. This creates the gap between the endothelial cells, and this causes the neutrophils and leukocytes of other types come out of the lumen, and they degranulate and release their granule products, causing local tissue damage and inflammation. So this happens because of the upregulation of this cytokines and the receptors or the ligands on the white cells. So this is the basic principle of any inflammation. So when this happens, therefore there will be more binding of the TNF and IL-1 with their receptor, or there is also leukocyte adhesion molecule and the ligands like ICAM1. So this all binding leads on to the white cells to get stuck to in a receptor ligand relationship, and they move slowly on the endothelial surface. They roll and they come out, as you have seen in this diagram. So this principle is not only for vasculitis, this is applicable to any inflammation in the body. So what happens is the basic principles of inflammation include that the leukocyte is captured, as I've shown, on the endothelial surface by binding between the receptor and the ligands of various kinds. They roll, and they roll slowly over the endothelial surface. Then they get little stuck on the endothelial surface by firm adhesion, and they transmigrate and they come out and release the granules products, which releases various chemoattractants on the tissues, cause local tissue damage. And that's the broad principle of any inflammation, including vasculitis. So this is a picture how the necrotizing vasculitis can affect the endothelial surface, the intima, media, adventitia. In cases of large vessel vasculitis, in medium vessel, they usually have, they do not have have all the layers. They mostly have in the media, predominantly, and the intima. So the classification of vasculitis are broadly classified as large vessel, medium vessel, and small vessel vasculitis. Here it is very important to understand the large vessels are basically aorta and its main branches at origin. Beyond the origin, the branches of main branch of aorta beyond the origin are no more large vessels. They become then medium vessels. And when they lose the muscle coat on their wall, they become the small vessels. So the large vessels are the aorta and its main branches and the analogous veins. Medium vessels are the main visceral arteries, like the renal arteries beyond the origin, and the veins in the initial branches. And the small vessels are the intraparenchymal branches, like the intraparenchymal branches of renal arteries, arterioles, capillaries, venules, etc. So the aorta and its main branches at origin are large vessel. Beyond the origin, the main branches become medium vessel till they lose their muscle coat in their wall and they become visceral, smaller arterioles, capillaries, venules, etc. They become small vessels. So accordingly, there can be large vessel vasculitis, medium vessel vasculitis, small vessel vasculitis, which can be again divided into ANCA positive and ANCA negative. Various overlaps can happen. A medium can have large vessel component, or a medium can have small vessel component, and so on. And there are some unclassifiable. This is a very broad, practical, oversimplified classification, but there is much more to it. I'll come to it. So large vessel, as I mentioned, aorta and its main branches at origin, medium vessel branches beyond the main origin, branches of aorta till they lose the muscle coat on their wall, and small vessels are the remaining terminal arteries, capillaries, and venules, etc. So this picture shows the aorta and its main branches. The main large vessels are giant cell arteritis, seen predominantly in the Caucasian population, and Takayasu's arteritis is the large vessel vasculitis more common in our population. So this is important to know. Whereas we have classic polyarteritis notus and Kawasaki's disease, which involve the medium vessels. As you can see, it involves the renal artery beyond the origin, so it becomes medium vessel. They can also have some small vessel involvement. Kawasaki's in children. And the small vessel vasculitis, ANCA positive, can be microscopic polyangiitis. Vaginous is now called GPA or granulomatosis with polyangiitis, and Chuk's-Strauss vasculitis is now known as EGPA or eosinophilic granulomatosis small polyangiitis. You also have non-ANCA small vessel vasculitis like Henoch-Schwann purpura, now called IgA vasculitis, essential cryoglobulin vasculitis, anti-glomerular basement membrane antibody-mediated disease like the Goodpasture syndrome, etc. So you can see here that the most large vessel vasculitis do not have much of medium or small vessel involvement. The classic medium vessel vasculitis can have medium and some small vessel involvement. ANCA vasculitis can have both the small vessels as well as medium vessel involvement, whereas pure small vessels are predominantly pure small vessel vasculitis like cryoglobulin or HSP or IgA vasculitis, etc. So this classification is again shown here. This is the extent of involvement of the large vessel. The medium vessel is predominantly this area, and the small vessels are here, which can be again ANCA vasculitis and non-ANCA small vessel vasculitis. So the spectrum of vasculitic disorder, therefore, again, it shows the GCA and Takayasu are the large vessel, classic PAN and Kawasaki are the medium vessel, and ANCA positive and ANCA negative small vessel vasculitis. ANCA positive, which vaginous is called the GPA, Chuk's-Strauss EGPA, and microscopic polyangiitis. ANCA negative vasculitis include HSP, which is also known as IgA vasculitis, rheumatoid, Sjogren's related SLE or Sjogren's or cryoglobulinemia associated vasculitis, are small vessel ANCA negative vasculitis, and various vasculitis related to drugs and infections like hepatitis B and C can be also predominantly small vessel vasculitis. There are also overlaps like Debashish syndrome can have large, medium, and small vessel involvement. Polyangiitis overlap can have large and medium. Also, some are little unclassifiable in the older classification, like vasculitis in antiphospholipid syndrome, which is predominantly a thrombotic disease, but can also have vasculitis. Burgess disease, thromboangiitis obliterans seen mostly in smokers. Paniculitic disorders of different kinds, and the CNS angiitis vasculitis, primary CNS vasculitis. These are the little unclassifiable So new classification came in 2012 of Chapel Hill classification. As you can see, the names have been changed: GPA, EGPA, IgA vasculitis. They've also added hypocomplementary arterial vasculitis or anti-C1q vasculitis. These changes have come. The names have been changed because those names are associated with the Nazi government of Hitler, and therefore their names have been removed and new names came. So the Chapel Hill classification, I would like to share with you the 2012 classification, a little change compared to the older classification. What is more important is that they have now classified Behçet's and Cogan syndrome, which is interstitial keratitis, deafness, and aortitis, under variable vessel vasculitis. There's also called primary CNS vasculitis is put under single organ vasculitis. Vasculitis is systemic diseases where rheumatoid, sarcoid-related vasculitis, lupus vasculitis comes, and vasculitis associated with probable etiology include hepatitis B, C, syphilis, drug-associated, cancer-associated vasculitis. So you can see that there was 1994 Chapel Hill classification, which is changed here, which include now, as we have seen, that there is also variable vessel vasculitis, single organ vasculitis, vasculitis with systemic disease, vasculitis with probable etiology, which I have mentioned. These are the changes of 2012 classification compared to 1994. In between, there was Anthony Fauci's classification also, which is also somewhere somewhat similar to 1994 classification. So then the DC-VAS classification work started from Oxford, which eventually merged with is ACR and EULAR, and new classification came last year. I was one of the largest contributor in the DC-VAS study. Now, the clinical presentation in vasculitis, therefore, it depends on either because of hemorrhage or ischemia or inflammation. So these are the broad causes for various symptoms of vasculitis. There can be some perivasculitis, which is not same as vasculitis. So sometimes in biopsy, if you see it, you can ignore that. So the common clues to suspect vasculitis is usually it is a multi-system inflammatory process. It can present with pyrexia of unknown origin. It can present with unexplained constitutional symptoms like weight loss. It can present with ischemic signs and symptoms like digital, central nervous system, bowel, skin, or eye involvement. Skin lesions of vasculitis involve palpable purpura, livedo reticularis, subcutaneous nodules, punched out ulcers, digital infarctions, splinter hemorrhages, hemorrhagic macules, and urticaria lasting for more than 24 hours. So these are the palpable purpura lesions, nail fold infarct. These are again splinter hemorrhages. This is again blistering hemorrhagic small vessel vasculitis. This is rheumatoid vasculitis healing, palpable purpura. These are erythema nodosum, very common. It can be caused by many causes. Periculitis is a histological diagnosis. If it is septate, it's called erythema nodosum. If it is non-septate, it is called just paniculitis. So only biopsy can differentiate that. So this was earlier called as a infantile pan or juvenile pan, but now I know that it is. We know that it is mostly because of DATA2 or ADA2 mutation in the gene. Kawasaki's disease very rarely can present like this. This is a non-healing ulcer. There can be many causes from pyroma gangrenosum to vasculitis. So this is a healed vasculitic rashes. This is a mouth ulcer in the Behçet syndrome. This is genital ulcer in Behçet syndrome. What is important here is in males it happens on the scrotum or the shaft of the penis rather than the prepuce skin. In women it occurs in the labia majora rather than labia minora. So as I've told you, the main clues to differentiate between large, medium, and small vessel vasculitis are absence or asymmetry of pulse or blood pressure suggests large vessel vasculitis. Systemic features like gross weight loss, foot drop, and wrist drop suggest medium vessel vasculitis, and palpable purpura suggest small vessel vasculitis. So you can also have wrist drop or foot drop both in a case of medium vessel vasculitis. Jaw claudication can be seen in giant cell arteritis. Hypertension can be seen in classic polyarteritis, Takayasu's, and occasionally vaginous microscopic polyangiitis. Also, testicular tenderness can happen in classic polyarteritis nodosa, and bloody diarrhea and crampy abdominal pain can happen in HSP, or which is now known as IgA vasculitis. So in GPA or vaginous, we can have ear, nose, throat involvement, migratory, cavitating nodules, and lung and renal impairment. EGP or Chukstras can have preceding asthma, eosinophilia, and lung infiltrates. Microscopic polyangiitis can have hemoptysis and rapidly progressing glomerulonephritis. Mimics of large vessel vasculitis include fibromuscular dysplasia, coarctation of aorta, radiation fibrosis, retroperitoneal fibrosis, and neurofibromatosis. The fibromuscular dysplasia is a rare disease. It presents with a beaded appearance in angiography. And the mimics of medium vessel vasculitis include diabetes, leprosy, malignancies, cholesterol embolization, atrial myxoma, ergotism or thromboangiitis obliterans, and type 4 Ehlers-Danlos syndrome. Mimics of small vessel vasculitis include infective endocarditis, mycotic aneurysm with emboli, cholesterol microemboli, antiphospholipid syndrome, meningococcal and gonococcal sepsis, ecthyma and pseudomonas infection, HIV, hepatitis C and hepatitis B infection, cocaine and amphetamine addicts, and thrombocytopenia. Although it is a flat purpura, sometimes with severe skin bleed, it may appear like a palpable purpura. Clinical features for exclusion of a mimic, how is it? Whenever there is a new heart murmur, hectic fever, or splinter hemorrhages, suspect endocarditis. Cutaneous lower extremity digital necrosis, you should suspect cholesterol emboli. Deranged liver function test, suspect hepatitis C and B. And drug abuse history, like cocaine, or related IV drug abuse can have HIV or hepatitis C, should be also considered. And of course, malignancy whenever there are a lot of odd features. How to investigate a suspected vasculitis? So eosinophilia may be a clue for Churg-Strauss or EGPA. Neutrophilic leukocytosis, sometimes in leukomoid reaction range, can happen. In classic polyarteritis nodosa, GPA or vaginous, microscopic polyangiitis, as well as in other small vessel vasculitis. Urine sediment or high creatinine can happen in ANCA vasculitis, whereas in classic polyarteritis nodosa, you do not get urine sediment. So I'd like to mention to you the correction. Urine sediment happens in only in ANCA vasculitis. In classic polyarteritis nodosa, there is only intraparenchymal branches of the renal artery with aneurysm, but there is no glomerulonephritis to cause hematuria. So CPK elevation can happen in most medium and small vessel vasculitis. So chest X-ray shows cavitating migratory nodules or infiltrates, suspect ANCA vasculitis. PNS also, X-rays and CT also can show changes as in GPA, sometimes in EGPA. Hemorrhagic infarct in the brain may be a suggestion of primary central nervous system vasculitis. And bowel infarction in the CT abdomen may suggest also a features of a GI vasculitis. This is a retroorbital infiltrate seen in a patient of GPA or vaginal granulomatosis. So this is a pulmonary hemorrhage, and same thing seen better in CT scan in GPA. You also can have low C3 and C4 in classic polyarteritis nodosa or vasculitis in rheumatoid arthritis and lupus, not in ANCA vasculitis. Cryoglobulins are positive sometimes in hepatitis C related vasculitis, sometimes in Sjogren's syndrome. C-ANCA or PR3 antibodies seen in 95% of GPA patients and small number of EGPA patients. P-ANCA or MPA antibodies seen in 80% of MPA and about half the patients of EGPA. Hepatitis B and C serology should be also tested, HIV also. So this is C-ANCA pattern in indirect immunofluorescence. This is the P-ANCA pattern or peripheral ANCA pattern in vasculitis, ANCA vasculitis. P-ANCA pattern seen in a magnified picture in peripheral anti-neutrophil cytoplasmic antibody pattern. ANCA testing was normally people recommended both in the past, but nowadays people say ELISA alone is enough. You don't have to do indirect immunofluorescence, and there can be 10% false negativity with either method. So the test like blood culture can to be done to rule out endocarditis, echocardiogram again to rule out endocarditis, hepatitis B, C, HIV, sometimes parvovirus in children, herpes, and there is a features of headache and seizure, etc. CMV vasculitis, especially in the setting of immunosuppressed patients, one has to look for these as a cause for vasculitis. Electrophoresis for myeloma, sometimes the malignancy associated vasculitis can present in a very odd way with multiple presentations, and myeloma after some age is also after 40 could be considered as a possibility. CSF for herpes and varicella zoster is also to be done. EMG and NCB to be done. If they're abnormal, we can decide to do muscle or nerve biopsy. Temporal artery biopsy in giant cell arteritis, muscle, nerve, kidney, lung, skin, testicular biopsy sometimes done in polyarthritis nodosa, but don't do kidney biopsy in polyarthritis nodosa because there can be torrential bleed because of microaneurysm. Nasal mucosal biopsy in ANCA vasculitis and brain biopsy sometimes in primary CNS leptomeningeal biopsy in CNS vasculitis. Fibrinoid necrosis with giant cells with leukocytoclasis, mononuclear infiltrate in the vessel wall in large vessel vasculitis, eosinophils in EGP or Chuk's vasculitis, and neutrophils can be there in all other types of vasculitis. So these are the classic features whenever you do a biopsy to prove vasculitis. It can show the broad features as well as specific features of different types of vasculitis. So you can do a temporal artery biopsy both by ophthalmologist or by radiologist or by a surgeon, and you can see that it's a very small procedure and doesn't leave a big problem. So this is the necrotizing vasculitis pattern, and it can give rise to a crescent formation, as you can see here, in very severe vasculitis like RPGN and ANCA vasculitis. So the imaging, there are many types of imaging from ultrasound Doppler to CT, MRI, PET-CT, all are being done apart from conventional angio. The angiography, people prefer nowadays more of CT angio. In the initial diagnosis, PET-CT or PET-angio also good, and MR angio and is also done whenever the contrast is an issue. MR contrasts are much better. The DSA or digital subtraction angiography or conventional angiography still had much better resolution, but it gives a lot of contrast, so it cannot give in all patients. It's very useful in Takayasu's and sometimes in classic pan to see aneurysm in the abdominal vessels. Some use in primary CNS angiitis. I'll show you some pictures. So this is a Takayasu arthritis, the complete occlusion of the left common carotid artery. It's a long tapered, narrow distal aorta and the iliac vessels in Takayasu arthritis. Again, the narrowing of the proximal descending aorta and the right brachiocephalic trunk, as you can see here, are affected. So this is a contrast enhanced ultrasound, which is rare. Earlier, ultrasound never had a contrast. Doppler never had a contrast. So advanced ultrasound now they have contrast enhanced ultrasound, which is very good. In the patient of Takayasu with extensive vascularization and intramedial medial layer and micro bubbles are seen in carotid artery. So the CT angiogram in large vessel is showing in the early disease maybe thickening of the vessel wall in the ascending aorta, whereas in a late disease you can get slight thickening and more of calcification. So this is 3D reconstruction CT angiography, which shows the stenosis and aneurysmal dilatation of the brachiocephalic artery, and you can see the left carotid artery and the left subclavian artery are narrowed, whereas in addition there is also stenosis in the right pulmonary artery. So in MR angiography in large vessel shows again thickening of the right carotid and subclavian artery in this patient, and there is a post-stenotic dilatation, as you can see here, of the carotids. Here also you can see of subclavian and stenosis of the thoracic aorta also seen. So primary CNS vasculitis, you can see beading again here in the middle cerebral artery and the left posterior cerebral artery distribution. So the FDG PET scan, the PET CT, it can be done. PET MRI also can be done. In large vessel vasculitis shows the aorta is lighting up with activity. And microaneurysms, as you can see, small microaneurysms are there in muscular arteries of the kidney or renal artery. Same thing in classic pan, the aneurysms can be seen better in an autopsy, you can see. So here the classic pan have a lot of microaneurysms again in angiography. This is CMV vasculitis in the retina in a HIV patient. This is a primary CNS angiitis which looks like a bleed in the brain and bleeding into the left parietal lobe, a complication of the central nervous system vasculitis. Diffuse narrowing and dilatation of the blood vessels throughout the brain involving multiple vascular territories, as is seen here in this patient of primary CNS vasculitis. The images of some of the rare mimics of vasculitis, I told you Ehlers-Danlos syndrome can also have this type of infrarenal aneurysms. You can see it here. And you can also have fibromuscular dysplasia with beaded appearance here. You can see much better in the CT angio. The segmental medullosis, isolated dissection of the celiac artery, which is consistent with segmental arterial medullolysis. So these are differentials. How do you diagnose suspect in presence of the clues I mentioned? I told you the clues like pyroxia of unknown origin, loss of weight, other systemic features, palpable purpura, etc. Classification criteria for all the vasculitis are there, and last year most of the vasculitis criteria has been revised by the ACR and EULAR. The supporting evidence include blood tests, various serology, imaging, and histology, which I have mentioned to you. And careful exclusion of the mimics are very important, which I have mentioned to you. So, individual disease criteria, you have to refer. This is, I don't have the time to describe each of them. It is available openly in arthritis rheumatism as well as in many other sources. Most of them are revised in last year. How to treat vasculitis? So conventional approach is steroid plus cyclophosphamide or mycophenolate in ANCA vasculitis and medium vessel vasculitis. In non-ANCA small vessel vasculitis, mostly are treated by steroid alone. Sometimes they may not require any treatment at all. Occasionally, on a very refractory or relapsing disease, we may have to give second-line agents like mycophenolate and azathioprine. Prophylaxis of calcium and vitamin D in patients on long-term steroid is also very important. So this is also a very interesting molecule, rituximab B-cell blocker, which has come earlier, 2010. There was several trials. So this is one trial of rituximab, RAPE trial. This is rituxivas trial. Both of them showed that rituximab is effective. It is comparable to cyclophosphamide and it doesn't have many problems. Rituximab versus azathioprine as a maintenance was also compared. So rituximab was found to be non-inferior to cyclophosphamide. And there are also various other drugs which are used. People have found that even drugs like mycophenolate, etc., are also effective. Rituximab has been tried both in induction and maintenance. In Takayasu, immunosuppression in acute phase and stenting and bypass in advanced fibrotic stage is needed. Successful use with mycophenolate we have documented. So if you see that the various pathways involved in vasculitis and large vessel vasculitis, especially the targets can be many. So you can have IL-6 as a target, you can have IL-23 as a target, you can have co-stimulatory molecules, you can have also the Th17 pathway as a blockade target. So basically, in large vessel vasculitis in Takayasu, TNF-alpha, IL-6 are thought to be the predominant terminal cytokines which leads to triggering of inflammatory process. Some role of Th17 and B cells are also implied. So we are the first one to use actually tocilizumab in Takayasu arthritis with a very good result. And tocilizumab actually helps in reducing the steroid dose very fast. Although it is a short-lasting benefit, you stop most patients relapse unless you have them on a second-line agent. And Takayasu therapy involves broader drugs like corticosteroid, mycophenolate, cyclophosphamide, methotrexate, cyclosporine. They all are broad spectrum. They act at multiple levels. However, as I mentioned, you can use anti-TNF blocker sometimes in Takayasu. You can use IL-6 blocker, you can get Th17 blocker. Rarely people have reported even B-cell blockers have been successful in Takayasu. So for aggressive vasculitic disease, ANCA vasculitis and medium vessel vasculitis, IVIG sometimes is a good option. It's very expensive though. Rituximab is also relatively cheaper now because of biosimilars and can be also a good option in very aggressive disease. And plasmapheresis, especially ANCA vasculitis, is very useful. So intravenous cyclophosphamide and plasmapheresis have been studied, and intravenous cyclophosphamide with corticosteroid and plasmapheresis have been a very effective alternative to oral cyclophosphamide in patients with dialysis-dependent ANCA vasculitis. The classic pen in ANCA vasculitis, apart from oral steroids and cyclophosphamide, was originally oral, as per the NIH criteria, shows improved survival. However, it's also very toxic. Pulse cyclophosphamide is found to be almost equally efficacious with much less toxicity. In UVAS trial, after 3 to 4 doses of monthly pulses of cyclophosphamide, followed by azathioprine, the people have found to be having a better outcome. MMF, we have found a very safe option. It should be spaced out with food, and the dose can be 2 to 4 grams per day. It is as effective as cyclophosphamide if the serum albumin is not low and if the patient can tolerate. And the disease is not very aggressive. A co-triamoxazole prophylaxis helps. It was first used by NIH protocol in ANCA vasculitis because it inhibits staphylococcus. So staphylococcal superantigens are thought to be triggers for triggering ANCA vasculitis. IVIG, as I've told you, expensive, but in refractory cases, in presence of doubtful infection, it's a very good option. But it's a stopgap measure. Again, the benefit lasts not more than 3 weeks. Rituximab is a very good option in acute severe disease. The special situations, you have to use antiplatelets, especially in large vessel vasculitis, to prevent secondary thrombosis in the endothelium. Mycophenolate is coming up, as I told you, is a better choice. Rituximab is coming up as a very good rescue option in crisis. So polyarteritis nodosa was studied in northern India. We have found that there is a high association with hepatitis B in classic polyarteritis nodosa. So in this study, it was found that there was no difference in outcome between hepatitis B and non-hepatitis B related classic family. The Behçet's disease, there is steroid plus azathioprine, steroid plus cyclosporine, steroid plus colchicine, etc. are used. But TNF blockers have been the most dramatic of all. As I mentioned, the RAPE trial and rituximab trial established rituximab as a very effective agent in vasculitis, and we are using it. TNF blockers in Takayasu and Behçet's also used, and tocilizumab is a very good stopgap measure. It can cut down the disease activity within 1 or 2 weeks. So disease activity scores are there. There are various disease activity scores. I'm not going into that. There's Birmingham Vasculitis Index, etc. And damage scores are like VDI, etc. there. The recent understandings, basically, JIVA studies have shown that in ANCA vasculitis, patients with PR3 ANCA vasculitis has HLA-BP association, genes encoding alpha-1 antitrypsin, and PR3 is found to be significantly associated with higher odds for disease. Patients with MP ANCA also had some JIVA study which shows HLA-DQ was found to be more significant. However, there is no association between CTLA4 and PTPN22 in ANCA vasculitis. So basically, there are distinct subsets in ANCA vasculitis. So there are some which are mostly related to chromosome 6, which is mostly HLA-related genes. Also, there are some genes which are related to the chromosome 13 and 14 are also there. So basically, it showed that ANCA vasculitis can have different types of genetic basis and presentation. So to conclude, you suspect vasculitis in unexplained systemic inflammatory presentation. Look for type of vessel involved, whether there's absent pulse, mononeuritis, or palpable purpura. Absent pulse means large vessel, mononeuritis means medium vessel, palpable purpura means small vessels. Histology, angio, and ANCA in appropriate situations we must do, and non-ANCA small vessel vasculitis may respond to steroid alone, and sometimes they don't require any treatment at all. So steroid plus cyclophosphamide or mycophenolate is crucial in large, medium, and ANCA-associated vasculitis. Rituximab in acutely ill, very aggressive medium and ANCA vasculitis can be life-saving. Tocilizumab can be rapidly acting and steroid-sparing in Takayasu, and TNF blockers can be effective options in refractory Takayasu's and Behçet syndrome. So thank you very much for patient hearing.